Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Evite.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi everyone, thank you for joining me on tonight's Egg Whisperer show. If you haven't joined me on this show before, I just want to say welcome. I really hope that whoever you are, wherever you are, whoever your doctor is, that you can use the tips and tricks, I don't know so much about tricks, that I teach you on tonight's show and apply it to your next cycle. Whether you're doing an endometrial receptivity assay or a frozen embryo transfer, certainly you're going to learn a lot tonight as I go through my process and a step-by-step guide to how I do the endometrial assay for my patients. So I kind of just told you what it is. What is the ERA test? It stands for Endometrial Receptivity Assay. I might call it the ERA as I'm talking about on the show. Some people call it the ERA test. They're kind of all the same. So thank you for joining me, and I hope you'll learn a lot. So let's talk about partying. I am literally one of those super annoying people that's always positive. I wake up each day and I kind of do this on purpose because I deal with stuff that's pretty heavy as a doctor. And with that being said, I have to be in a mindset where I feel like I'm going to look forward to just starting my day, seeing patients and helping people. So that's why I think of the Embryo Transfer Day as one of the most important days in my patients' lives. They have prepared so much, done so much work, and I want to go prepared as well. So the ERA test is one thing that I do for them. So imagine this scene. You've been invited to a pool party, right? You've been given a time to show up, and you show up and no one's there. And you realize that you got there too early and now you're feeling like a huge dork. I've done this before. Showed up on the wrong day actually. And you go back home. Same thing. You think the party's at a certain time and you show up too late and everyone's gone. Maybe there's like one person that may have had just a little bit too much to drink still straggling there. And you're like, oh, I totally missed the boat here. This looked like a really great party, but I'm gonna have to leave. That's how I think about the ERA test. I think about it in a way as your evite for your embryo transfer or your embryo transfer party, right? So it's that one invitation, and you all know what an evite is. You get them all the time, I'm sure of it, telling you exactly what time, what day to show up. But think about this. Think about also when you show up to a party and you're given an evite, don't you also think about the attire that you're going to wear? This actually happened to me. One of my dearest, closest childhood friends, she invited me to her wedding. This was about 10 years ago. And I clearly missed this in the invitation. And the invitation, I'll just tell you what happened. I showed up wearing a red dress. And everyone else was in black and white. So it was a black and white themed wedding. And I clearly missed the memo. She was so sweet to me. She's like, you look gorgeous. And I'm like, I feel like an idiot right now, but everyone understood and everyone was totally cool about it. So think about doing this testing as not just telling you when to show up, but also what to wear. Your attire. Another way of thinking about it is the protocol that's going to be used for your embryo transfer. So protocol for me isn't necessarily the ERA test. There's another test that I do at the same time. When you do one biopsy, and I'll talk a little bit about the details of that, I send the cells to two different companies. One company tells me about the number of progesterone hours a patient needs in order for implantation to occur, and the other company tells me about inflammation, infection, and microscopic polyps. Super important information for me so that I make sure that those embryos are ready and the protocol is done in the right way. In a way, think about it as having the right attire for the party and showing up at the exact same time so that embryo sticks around for 9 months. So on tonight's show, this is what I'm going to talk about. I'm going to talk about exactly what the ERA test is, what medications you take, how will the meds make you feel, how is it done, when will you get the results back, and lastly, what will it tell you? So no matter, again, who your doctor is, take these questions in, talk about the test, ask these questions, and make sure you have the answers beforehand. And that's why I talk about the ERA test before. My patients are so lucky to get 1 or 2 embryos even from one IVF cycle because most of my patients are over the age of 39. So I take what I do with the embryos so seriously. I want everyone to get pregnant. I wish there was such a thing as a 100% pregnancy rate, but at the end of the day, there isn't. You know, IVF with genetic testing is like the murkiest of all crystal balls for sure, but it's the best we have. So I recommend to patients that they consider it. But it's not 100%. So what can I do to bridge that gap between maybe a 85% chance of pregnancy to give my patients as close to 100 as I can? And so that's where these tests, I think, can fill or bridge that gap so that I'm doing everything that science can offer my patients to give them the best outcomes. So the time to talk about these tests for me isn't after a failed transfer, but certainly there are patients out there that have doctors that talk to them about these tests afterwards, but I want patients to know about these things ahead of time. And then you certainly have the choice then to do the test or not. And if you choose not to do the test, then you're gonna feel like you were at least given the chance to decide whether it's right for you or not. And then you can, if a transfer doesn't work, feel really good about the fact that you did what was right for you at the time and move on and not have any regrets at all. But this is the thing some people think. They think these tests are for people who have, for example, never gotten pregnant. So I have patients who have something called secondary infertility, and they've gone through IVF and they've had transfers, and they think things like, well, I've gotten pregnant before, so I don't really need these tests. That may not necessarily be the case. So you still might want to consider them, and I make the decision based on how many embryos my patients have, what they've been through before, how many transfers they've been through, for example, and how many kids they want. And I even do these tests on people, for example, who have donor egg embryos. And I also consider doing this test on patients who are using a surrogate. I have surrogates go through this test because once you get to the point of being ready to use a surrogate, success matters so much. I mean, it matters so much for everybody. Every single one of my patients to me is definitely VIP, and hopefully will carry a VIP or a very important pregnancy very soon. So when you get to that step of wanting to use a surrogate, especially if it's a first-time surrogate, these are sometimes tests that I still consider doing, and something that I'm seeing other doctors are doing too. So now let's talk about what is the ERA test. So this is an example of a result, and the result findings are receptive. So what does this mean? Sometimes I hear people say things like, oh, the ERA tells me exactly when to transfer, what day to do it. And that's actually not what it tells us. In a way, it kind of does, but I'll tell you more about what I mean in a second. Imagine this is a lining, okay? Nice plush endometrial lining. They have receptors, okay? Think of them as genes. So they're genes that get expressed, and I'm just gonna kind of show you, this is a gene, for example, that's getting expressed. After so many hours of progesterone, that gene is expressed and ready for an embryo to sit down and implant, okay? So everyone's body needs a hormone called progesterone. Progesterone stands for promote pregnancy. Progesterone, promote gestation, right? So everyone is different. Everyone's progesterone needs are different. Everyone potentially needs a different number of progesterone hours in order for implantation to occur. And we call that the window of receptivity. That window is approximately 24 hours. So what this test does, it's a test on the lining of the uterus. We have to remove cells, and next generation sequencing is done, meaning genes are evaluated. So there's a whole bunch of genes that are looked at related to implantation, and the expression of those genes then tells the scientists at the company this number. This is the number I think about and that I'm most concerned about. Let's see if I can point to it. It says 131. So for this person who got this report, they were told that their uterine lining was receptive in the way that I did the test for them, and that their number is 131. So it doesn't mean that I now know what day to do the transfer. I can still pick my transfer day based on the simple rules that we use, and I'll go through the simple rules. You literally can be a fertility doctor after you watch this show. Maybe not quite, but almost. So you pick your transfer day, and then you calculate backwards 131 hours, and that's the exact day and time that you will start your progesterone. And I like things to be as exact as possible because I literally have to go to sleep at night knowing that I literally did my very best for each patient and gave every embryo their best chance of implanting. So, what medications do you take? Well, the concept is this: we're trying to mimic ovulation. So there are different protocols, different ways of doing things. We start off with estrogen. Estrogen is secreted by the ovaries when we ovulate. Estrogen levels rise. And then after ovulation, progesterone levels rise. So basically what we do is we use about 2 weeks of estrogen, and then the third week we combine with progesterone. Different options for estrogen. You got pills, you got patches, you got shots. So if I have a patient that's forgetful and she keeps forgetting the pill, and I talk to her about this, so I talk to everyone about these things, then I'll say, you know what, I think maybe either the patch every other day or the progesterone shot every 3 days will probably be best for you. But once you say words like shot, everyone's, oh, I don't want a shot, and I don't blame you for not wanting a shot. So then we choose estrogen pills. So the name for that, estrase, estradiol, I also call it just estrogen. They come in little blue pills, and you take them twice a day, 2 in the morning, 2 at night. And I like to give my patients instructions. I just say, pick 8 a.m., 8 p.m., 7 a.m., 7 p.m., 8 and 8, 9 and 9. Just stick to a regimen. Because if you miss your pills, if you are doing them at random times during the day, what can happen is you can start ovulating. These medications are supposed to take over your cycle. So the cycle that you know it from when you, based on when you ovulate, is no longer. So one of the things you actually can do is have sex and not worry. Not that anyone's worried about getting pregnant naturally, but sometimes when you've gone through all the work of creating an embryo, you're afraid to have sex around these types of tests because you think that maybe you could get pregnant. I mean, that's certainly always welcome and a wonderful thing, but you can definitely have sex for fun and not worry. So 2 tablets twice a day. I also recommend vitamins and aspirin. The aspirin, some patients say, oh, is that optional if I have a headache? And the answer is no. I want to prevent clots when patients are on these medications. High dose estrogen could potentially, and it's not super high, we're just mimicking the same level of around ovulation, but I'm always concerned about side effects of things, and I want to make sure my patients don't have any complications, and that's the main reason why I use a tiny dose of aspirin, 81 milligrams every single day. So you just take that for about 2 weeks, and then you learn how the medications make you feel. So all hormones have side effects. Talk to your doctor about the side effects. So when you're mimicking ovulation, guess what? You're going to feel like you're ovulating. You might feel some breast tenderness. You might get some egg white cervical mucus after a certain number of days. Don't panic. Don't be concerned. That's normal. You might get headaches. You might get a little nauseous. So depending on how you feel, talk to your doctor because things can be changed based on your symptoms so that you can go through the cycle and not feel like you're losing your mind. So I have patients that call me and they're like, Amy, these medications are making me feel like a crazy person. And I say, okay, exactly what your symptoms are, let's address them. So for example, one of the things that you can do is actually adjust the dose. Don't take 2 tablets twice a day, maybe take 1 tablet 3 times a day, or just 1 tablet and place it vaginally morning and night. But I have to alert you, you might have something called Smurfgina. The pills are blue, the discharge is blue. I think you know why I said that. So I just thought that was very funny right now, so I'm just trying to get over my humor. So now, how is the test done? The test isn't as simple as just doing a blood test. I wish. So basically, after 2 weeks of the medication, you come in for a lining check and blood test. At the time of the lining check, we want to make sure that your lining thickness is between 9 and 12 millimeters, that's the goal. And we want to make sure that your progesterone is nice and low as well. So now I'm giving you these parameters and I want you to know there's so much flexibility. It's not just about the thickness. We like to see a beautiful texture that has 3 lines in it. And so sometimes the patient's lining is like 8.5 millimeters, so close. That's okay. I don't want you to watch the show and then go tell your doctor, well, Dr. Amy said 9 millimeters. No, don't do that. And sometimes the patient's lining is perfect and it's 14 millimeters. That's okay too. But in general, we like a lining that's around 9 millimeters to 12 millimeters and a progesterone that's basically undetectable, less than 1. Once we have that, I then review progesterone options with patients. There are also several options for progesterone, but the theme is vaginal or injection. Very rarely I have used oral progesterone only for cycles like this. There have been only 2 situations that I really had to, and that was because the patient had severe reactions to the other types. So with the vaginal progesterone, this is a great run through because when you're using the vaginal progesterone, I'm going to use this saying, and it sounds really awful, but if you skip 1, the pregnancy could be done. You see, when you use the progesterone shot, it's an oil, and there's a buildup in the system. Not so much when you're using vaginal progesterone. There isn't a buildup. So you reliably have to place the insert 3 times a day. And again, I give my patients instructions, 8 a.m., 2 p.m., and 8 p.m. on the dot. Does it really have to be on the dot? Probably not. But if you want to practice and consider this your rehearsal cycle, your mock cycle, your implantation testing cycle, This is a good test to see if you can reliably take your medications on time and never skip one. If you find that you're having a hard time remembering, obviously there are things that you can do. Phone alerts. Have someone call you 3 times a day to make sure you did it. That's a good call. Or a text. Did you put the tablet in your vagina? Yeah. And then with the progesterone shots, I'm telling you, these things hurt like heck. If you haven't watched my injection instruction video, I've actually given myself a shot. And so I'm going to do it again tonight. Just kidding. I'm really not. But I'm just going to show you my tips real quick here because this is what I share with my patients and I want you to learn this stuff too. For the progesterone injection, okay, after you draw it up, first of all, I use ethyl oleate, 100 milligrams per ml. So it's concentrated as a double strength dose so that patients don't have to take 2 mLs. My preferred dose is 100 milligrams, but talk to your doctor. Every doctor is different. After you draw it up, put it in your armpit. Make sure you've showered. Pew! Just kidding. Keep it there just to warm it up just a little bit. I've seen people do things like put the jar in the microwave and stuff. Like don't ever do that. But just warming it up a little bit might make the oil just a little bit easier to go through. As you're doing that, put an ice pack on your tushy. Let it get nice and cold so that when you or someone else is doing your shot, you're not giving them the look of death. No looks of death, okay? And then what you'll do is after the shot, so I'm just going to lean my little butt up and here I'm going to go. So you're here. What you're going to do is just pull back a touch, make sure there's no blood there, inject, come out. Don't freak out if you see a little drop there, a little blood there. Put a little gauze and do a little rubby. Get someone to give you a nice butt massage with maybe some heating blanket and one of the hand vibrators. Not a vibrator, a hand vibrator. And that's basically how you do the shot. You're only going to do it for 6 days for this, but in the real deal, you're going to be doing it through 10 weeks of pregnancy. The day of your transfer, if you're doing a blastocyst transfer, you're considered 2 weeks, 5 days pregnant. So then basically a little over 7 weeks later, you're going to be done with the shots, but certainly you can do things like, this is what I talk to my patients about, maybe just doing the shot during the week when you're working and doing the inserts, giving your butt a break on Friday night, Saturday night, and Sunday night, and doing shots the rest of the week. So lots of things that you can do to make your butt less sore as you're going through this process because your butt can get really, really sore. So now, when will you get results back? Huge question. Everyone asks me that, and I try and answer it before I'm like, oh, I know what you're going to ask me. You're going to ask me, when are you going to get results back? So I'm going to tell you. After the biopsy is done, you get results back about 2 weeks later. The good news is this. You don't need the results back until you do your next lining check. So you can still plan your calendar based on the rules that your doctor uses, the recipe that they think is best for their patients, and the recipe that they have the most success with. And then as long as you get your results back by your lining check, you're golden. You're totally cool. You get the results back and then you follow the rules for your transfer, okay? So what will the test tell you? Well, I already showed you a result that was receptive where, let's see here, that one was 131 and this one is giving a new number, 156. So in general, my patients mostly are receptive at around 134 hours. This patient is receptive as 156. So it's like, thank goodness we had this tool. Thank goodness I knew when to show up for that embryo transfer party for this patient, because now I feel really comfortable and ready to guide the patient as far as exactly how their protocol should be designed just for them. Okay? Bueller, just kidding. So how about this? Let's say you want to double check. See, I used to do all of this stuff by hand and it used to drive me crazy because imagine like calculating 24 plus 24 and figuring out exactly when the transfer was when. So I don't have to do that anymore. There are now all these really cool, I'm sure there have always been these really cool online calculator tools, but now I'm going to share them with you so you don't have to be that person doing it by hand. But you can kind of double check if you've done transfers in the past using this website, and I'm going to include these websites in the blog article that I'm going to write that will go along with this show so you can have access to them as well. So you can kind of double check what you've done in the past compared to what the ERA test tells you now if you're doing the ERA test after a transfer that didn't work. And then this is a really cool personalized embryo transfer calculator. And you can see here that you just put in where it says HRT, so hormone replacement therapy cycle or hormone replacement treatment cycle for your, hormone replacement transfer cycle. And you basically fill in all the cells here and then you fill in when you're going to do the transfer. You fill in how many total hours, like whatever that ERA, the number of hours were that the test told you. And then it tells you exactly what day and what time to start the progesterone. Super, super, super useful tool. So I've covered a lot of stuff today on the step 2 or the second month of how to get pregnant in 3 months or less. So I've done a show on that. And so basically I just broke down all of that second month for you tonight. So if you haven't read the blog article or watched the show about how to get pregnant in 3 months or less, I highly recommend that you guys do that. So before I end the show, I want to talk about the actual biopsy day. What I brought today was actually a curette. So this is what the packaging looks like. And I'll take out the curette for you to see. So this is what it looks like, okay? And so when you do an embryo transfer, you're putting the cells in and you're pushing something that's microscopic inside a uterus. So for patients who've had the endometrial biopsy, sometimes they're so freaked out that the transfer will feel the same way. I promise you it won't, because I'm just pushing cells in. When you do the endometrial biopsy, all I'm doing is pulling back on this, and cells that were once attached to the lining will now go into this pipelle, and that hurts. And then I remove it. I don't believe in causing patients pain. I consider, you know, those people that call themselves like the pain-free dentist. I try and think of myself as the pain-free gynecologist or the pain-free fertility doctor, but there's really no such thing. But I talk to my patients about pain and their fears and concerns, and this is why. The internet, everyone reads about this stuff, and this test sounds awful online. So I offer all my patients a Valium and a Tylenol with codeine 30 minutes before. I ask patients to come in with a full bladder so that I may do the test under abdominal ultrasound guidance if needed. I want to have a really easy time. I tell patients that I'm going to count to 5 and their pain score is going to go from 0 to 8 during that 5-second interval. And then after I remove the catheter, soon after it'll go down to 6. Within 10 minutes, it'll be at a 3 out of 10. Within 20 minutes, it'll be at a 0 out of 10. And everyone will want to pee right away because having a full bladder basically makes, let's say, a folded up lawn chair uterus nice and flat, super easy to get in, and no trouble at all. So this procedure assists with completing several things. Number 1, a mock embryo transfer. Number 2, doing the extra testing. Number 3, seeing how you feel on the medication so that if you have a reaction, you have time to troubleshoot what that reaction is so that you can adjust things for the real deal. So think of it as a dress rehearsal before the actual performance, because that day you want everything to be absolutely perfect. You guys, I could go on and on. I mean, I could keep talking about this forever. So thank you for watching tonight's show. I really hope that all the tips that I shared with you were really, really helpful. And again, no matter who you are, where you live, you can take the 6 questions that I listed at the beginning of the show to your doctor so you can learn more about the test, how it might help you, how your doctor will use it for you, and certainly what protocol they're using, why, what medications that they're going to use, the side effects that you'll feel, and more and more and more and more. So thank you guys so much for joining me tonight. I hope you guys have an awesome, incredible night. I'm sending you guys all sorts of positive vibes so that no matter where you are on your journey, hopefully it'll be over soon and you'll get the success that you so deserve. Have a great night. Thank you guys.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Evite,
And you have yet another success story.
Just launched by an East Bay fertility doctor.